Assalamu alaikum wa rahmatullah. Today's lecture is about electronic health records, health information exchange, and data standards and medical coding. Our learning objectives in this lecture are to state the definition of electronic health records, describe the limitations of paper-based health records, identify the benefits of electronic health records, and describe the benefits and challenges of computerized order entry and clinical decision support systems. Also, you will identify the need for and benefits of health information exchange, HIE, and interoperability. Describe the concept of health information organizations and identify the need for and benefits of different data standards for health informatics. And we will compare and contrast standards used for electronic health records. At the beginning, we will differentiate between three medical terms: personal health record, electronic medical record, and electronic health record. We will start with the personal health record. It's electronic record of health-related information on an individual that conforms to nationally recognized interoperability standards and that can be drawn from multiple sources while being managed, shared, and controlled by the individual. So the personal health record systems, they are more than just static records for patient data. They combine data, knowledge, and software tools which help the patients to become active participants in their own care. Anytime the patient move, switch healthcare providers or hospital, or seek medical treatment during a vacation or a trip, the health provider will ask him about his medical history. So it can be difficult to remember all of this information. But by having a personal health record on hand, that means the patient will know the answer when they will be asked, and these answers will be correct and accurate. So the personal health records can also save the patient in emergency situations. So if they were on a trip with friends and they had an emergency situation, the companions of the patient will not be able to answer questions about the patient health history and his current healthcare provider. In this time of crisis, it can be difficult to remember important and potentially life-saving information. But with personal health record, we can do that. Now we will talk about the information that can be included into the personal health record. So it can include any information regarding the personal health and the doctor name and the phone number or the basic information about the patient or the person, the allergies, including drug allergies, the medications, including the dosage, and list and dates of illnesses and surgeries, the chronic health problems, such if the patient or the person has high blood pressure, family history, and immunization history. Also, it can or some information can be added, uh, such as home blood pressure readings and daily exercise and diet habits, um, and the weight and the BMI calculators. All of this information can be stored in the personal health record. You could also use an app such as the health app for iPhones. So this is an example for the app that can be installed on your phone or smartphones. This app will include your medical ID, which makes critical information available uh, on the lock screen, or to be used by the first responders in an emergency situations. And it will display medical conditions, allergies, medications, blood type, and emergency contacts. So the electronic medical record, it's the electronic record of health-related information on an individual that can be that can be created, gathered, and managed and consulted by authorized clinician and staff within one healthcare organization. So the electronic medical record typically contain general information about the patient, such as treatment and medical history, and it is collected by and for the clinician in the office, that office or clinic or hospital. This information will be mostly used for diagnosis and treatment, um, and it includes information about diagnosis, medicines, tests, allergies, immunizations, and treatment plans. So the electronic medical records, they are more valuable than the paper records, because electronic medical records can be seen by all healthcare providers who are taking of the patient, and they enable the providers or the physicians to track data over time and identify the patients for preventive visits and screenings, monitor the patients, and improve the healthcare quality of the patient. So the electronic medical record work well within a practice, within one healthcare organization, but they are limited because they cannot easily shared outside the organization. So if you need to share your electronic medical record, uh, you need to have a request to print it out. Then you can take it or mail it to another provider to see it and review it. So the electronic health record, this is the end goal of having electronic medical records and personal health records. The electronic health record is electronic record of health-related information on an individual that confirms to nationally recognized interoperability standards, and that can be created, managed, and consulted by authorized clinician and staff across more than one healthcare organizations. As you can see at the picture, we have here three electronic medical record at three medical providers, and we can draw the information, or these electronic medical record can be source for the patient information to the electronic health record. And the electronic health record can be shared between different and multiple organizations. Uh, the personal health record can draw information or data from the electronic medical record and the electronic health record, but it will be managed and controlled by the patient or the person himself. So the key feature of the electronic health record that uh, it will be controlled by authorized clinicians and staff or providers, and the records or the data can be shared with other providers across more than one healthcare organizations. So the electronic health records, uh, are built to share information with other healthcare providers and organizations such as laboratories, specialists, medical imaging facilities, pharmacies, emergency facilities, and school and workplace clinics. So they can contain information from all clinicians involved in the patient's care. In recent years, there is a move to include other systems into the electronic health record, such as the computerized physician order entry and the clinical decision support system, which will are part of electronic health record in addition to patient information to facilitate the physician practice and improve the patient care. So in this slide, we will explain the relationship between the electronic health record, the personal health record, and the electronic medical record. As you can see, the electronic health record is the larger system that includes the electronic medical record and the personal health record. The electronic medical record, on the other hand, is the electronic patient record, which is located in a hospital or a clinic. The personal health record is a collection of health information by and for the patient. Uh, it it is those parts or include parts from the electronic medical record and the electronic health records. Um, and it will be on by the individual or owned by the individual and controlled by the individual or the patient. There is overlap between the electronic medical record and the personal health record, since the personal health record can be part of the electronic medical record. Uh, and the uses of the terms electronic health record and the electronic medical record, uh, it can explain that the word health is more encompassing than the word medical. Uh, and the term medical records implies that the clinician records for diagnosis and treatment, while the term health records more broadly denotes anything related to the general condition of the body of the patient. So why do we need to shift to electronic health record? Uh, First, to overcome the limitations of the paper-based records, because the paper-based records has handwritings, and this handwritings is illegible and unreadable, and the document cannot be electronically shared or stored. It doesn't have structured data that is computable, and for that it cannot be shared between or with other computers and system. Um, Another shortcoming for the paper is it is expensive to copy and transport and store, because we need to have rooms um, and staff to organize and store these records. And we need also staff to search and navigate between the records to find them. So more likely to be missing and unavailable, uh, because most of the time the the paper based records will be unavailable, because it will be missing or lost. So the physician, when he open uh, when he opens a large paper chart, uh, some loose lab results will fall out, and in this way the chart will be missing the result, and the result or the lab result need to be uh, retest uh, to have or to take the appropriate clinical decision. Also, the paper records do not permit automatic clinical decision support, because the data are not computable, so we cannot integrate the automatic clinical decision support system with the paper records. The second reason is to improve the quality of care and patient safety, and the electronic health record should improve the patient safety uh, through many mechanisms, such as improving the readability and clarity of clinical notes, and improving the accessibility from anywhere and anytime, and reducing the duplication of lab tests and x-rays. So the electronic health records allow easy navigation through the entire medical history of the patient, and it will be available 24 hours a day, 7 days a week, and doesn't require an employee to pull the chart from a chart room. And there is no need for extra space to store the electronic health record, and the adoption of the electronic health records will save money by decreasing the number of the staff, and the room that are needs to store and organize the paper chart. Um, it also improve the documentation and the completeness of the clinical histories. Um, and as we said, the goal is to have patient information available to anyone who needs it, and when they need it and where they need it. So with electronic health record, the lab results can be retrieved much more rapidly, and will save time and money. And the electronic health record will reduce the redundant paperwork and have the capability of interfacing with a different system electronically. And the also we don't need to wait for someone to retrieve the information from the paper chart. We can get the result by secure messaging, and the patient safety and reducing the incidence is an important goal of having electronic health records, because the electronic health records will reduce the medical error by improving the accuracy and the clarity of the medical records through different and many mechanisms, like improving the legibility of the clinical notes and improve the access anytime and anywhere, reduce the duplication of the test, and reduce reminders about the test, and also having clinical decision support system that can be integrated, and electronic problem summary list provide the main diagnosis, allergies, and surgeries of the patients. The third reason is to meet public expectation. So with having electronic health record, um, it may increase the patient satisfaction through faster results and messaging, patient portals, electronic patient education, and prescribing and online scheduling. So the electronic health record adoption results in better customer satisfaction, and the customer here is the patient, through fewer lost charts, faster refills, and improved the delivery of patient educational material. And also the patient portals that are part of the electronic health record are likely to be the source of the patient satisfaction, as they allow the patient access to their records with multiple other functionalities, such as online appointing and medication renewals. And another reason to shift to electronic health records is the technological advances that can support electronic health record now. So now the computers, they are much faster. The internet is more prevalent, and the wireless and mobile technology are ubiquitous, all supporting the electronic health records. So the timing seems to be right for electronic records, partly because the technology has evolved, and via the internet we can access the electronic health records from different locations anytime. The computer speed and the memory, the bandwidth of the network have also advanced, such that advanced some data, such as the digital imaging, because with the digital imaging, with the x-rays and the digital radiology images, we need to have high computer speed, large memory, and bandwidth. Uh, Also, the personal computers, the laptops, the tablet continue to add features and improve the speed and memory, while the costs drop. And we have also, as I said, wireless and mobile technology, which permit access to the hospital system or information system, the electronic health records, and the internet using a variety of mobile technologies. The other reasons are the need for aggregated data. So the healthcare data, they must be electronic to be shared, stored, and analyzed to provide significant statistical result for the research or evidence-based decision system or practice. So in order to make the evidence-based decisions, the clinician, they need high quality data that would be driven from multiple sources, such as inpatient and outpatient care, acute and chronic care settings, urban and rural care and populations at risk. And this is can be accomplished with electronic health records and uh, separated structured data. Um, so the data need to be also combined and grouped to achieve statistical significance. There is a need for data analytical tools to uh, analyze the uh, flood of data that will be generated from widespread electronic health records adoption, which result in big data. The need for integrated data. So the electronic data permits integration with health information organizations, data analytics software, public health reporting system, and artificial intelligence and genomic information. So the paper health records, they stand alone. They lack the ability to integrate with these systems. Um, but with electronic medical record, we have the ability to integrate and share information uh, with different organizations, and we can analyze the information and the data to find important and critical information to the future of healthcare reform. So we can integrate multiple internal and external applications with the electronic health records, such as health information organizations and data extraction and analytical tool to examine the pest treatment and pest practice. Also integrate local, state, and federal or governmental quality reporting and public health issues. And we can also apply algorithm and artificial intelligence and genomic information to the patient. To increase financial savings, decreasing the file room storage and faster patient shortfalls and info retrieval, uh, all of these may result in cost savings, and also it's likely to cut the expenses of the copying, faxing, and mailing the paper medical records, and uh, also the duplication of the lab test and X-ray. Uh, all of this will improve the saving of the money and time. Computerized physician order entry. This is a feature that can be integrated with electronic health records that process orders for medications, lab tests, imaging, consults, and other diagnostic tests. Um, and it can have many functionality. So it can send the medication order from the physician, and if you need a referral to another specialist, it will be ordered by the physician. Also, any medication or imaging test will be sent through the computerized physician order entry to the appropriate department. So the CPOE systems were marketed and sold as standalone system, but now they are a feature integrated with the electronic health records. And this is electronic prescribing, where this is a system that can be used for medications request and refills. So the potential benefits of CPOE or e-prescribing are fewer errors associated with ordering drugs with similar name, because it has the potential to reduce medication error through variety of mechanisms. Uh, Here the process is electronic. The user can embed rules or clinical decision support that check for allergies and contradictions and other alerts. It also overcome the uh, issue with similar names of drugs, uh, because sometimes the names of the drug will be similar and confusing, and with the handwriting, it can or cause uh, a medical error. Uh, for example, we have the first medical malpractice case was successfully prosecuted due to the illegible handwriting of the cardiologist, in which the illegible prescription resulted the patient death because the pharmacist interpreted the drug prescribed as uh, uh, Flindel and not Isridil, Isridil, sorry, Isridil. So um the Flindel drug was used to treat hypertension or high blood pressure, uh, and the Isridil uh, was used to prevent the angina pectoris, which is caused by coronary artery disease اللي هي الذبحة الصدرية. Um, and the pharmacist was confused between the two drugs, um, and this confusion resulted that the patient died, and the jury awarded for $450,000 in damages, with 50% of responsibility on the cardiologist and 50% on the pharmacist. So this is one case that uh, can clarify why it's important to have such system to order drugs. Easily linked to drug interaction warning. So there will some drug will be interacted with another drug or with another uh, substances like food or herbs. For example, um the drug interaction will have three possible effects. It can increase the action of drug or decrease the action of drug, and sometimes it cause adverse effects اللي هي تعرضات جانبية لل تعارض الأدوية. So with having warnings, the the pharmacist can change the patient or the dosage according to the warning or the decision system suggestions. So We are also, with having CPOE or e-prescribing, it's more likely to identify the prescribing physician because each physician will have his username and password to access the system. In this way, we can track who's the physician who prescribed uh, the wrong or the inappropriate medication to the patient. Um, Also, uh, it will be able, we will be able, or the system will be able to link adverse drug adverse drug event reporting system, where we will able to avoid medication um drug events or adverse drug events by reporting any adverse event for a specific drug اللي هي التعرضات أو الآثار الجانبية لبعض العلاجات في حالات محدودة such as for the pregnant patient or for uh, patient with problems in their kidneys or in their heart. So with having this reporting system, the physicians and the clinician staff will be alerted that whenever they prescribe the medication. Also, the system will be able to avoid medication errors like training zeros. So there will be no need for the zero. It will be taken off um, and remove and clear decimal points like here. The decimal point and the zero will be confusing. Some of the pharmacists can read it as 10 milligram instead of 1 milligram. So here the system will remove the zero for to overcome any confusion. And um, prescriptions and other tests will reach the pharmacy or radiology quicker because when the physician orders the prescription or the radiology or the lab test, he needs just to request the order, and by a click the order will be sent to the uh, department, and this will result a quicker service for the patient. Challenges of CPOE. So in the CPOC system, which can be used by different clinical staff and professionals, such as the physician, the nurse, and the pharmacist. For example, when the physician prescribe uh, the medication or the uh, test, it will be reviewed and supplied by the pharmacist, and then the nurse would administer the medication to the patient. If the physician use or write his request by his handwriting, and his handwriting was unreadable. In this way, it cannot be reviewed, supplied, or administered by the pharmacist and the nurse to the patient, and they need to return to the physician to clarify his request. So the CPOE is challenging to implement in hospitals because it disrupts the workflow and slow physicians down. By adapting CPOE, the workflow can be slow partly because of the cost and also because of the inputting. When the physician input his request using a desktop or a laptop or iPad, will be slower than writing on paper. And the physician usually are upset by new changes that do not shorten their workday, but having um, CPOE and electronic health records will improve the hospital functions. So others staff can recognize uh, the improvement uh, and will be more productive. But at the beginning or initially, the productivity of the physicians will be slow at the beginning until they be trained and um, uh, uh, the physician skills will be uh, improved, the workflow will be changed, and everyone in the practice will have to change the way they wrote information compared to the old system where they were using the paper system. The clinical decision support system with CPOE and electronic health record, we can uh, embed and add a variety of tools to assist in decision making, such as a clinical decision support system. Um, the clinical decision support system is a health information technology system that is designed to provide physicians and other health professionals with clinical decision support, that is assistance with clinical decision making tasks based on multiple factors of patient related data. So you can enter the patient data and main factors, and based on these data, the system will help you with the clinical, or will help the professional with the clinical decision making task by suggesting some lab test or order test to uh, to come with a diagnosis, or to find the illness of the patient. So in the clinical decision support systems, um, the system has different features. Uh, For example, we have the knowledge support. The knowledge support, they are programs embedded into the CBOE or electronic health record that educate the clinician or the patient. So there are numerous digital medical resources, and they can be integrated with the electronic health record and the CBOE. For example, there is the comprehensive online reference, up to date. I think most of you heard about the up to date database, where you can have all the clinical online reference to medical and medical practice. It has been integrated into 6 electronic health records, and other systems and other knowledge support system integrated with different electronic health records, such as the iConsult. Um, and also there is a diagnostic codes, which can be hyperlinked, and also more information can be available to the user by using an info buttons where you can have more information about the case. And there are also other tools such as antibiotic assistant system, where uh, this program suggests the antibiotic of choice with multiple alerts. And there are um, a system for adverse drug event assistance and infection control assistant and clinical alert assistant. So all of these are knowledge support systems that can help the physician. The second tool is the calculators. For example, um, with the calculator will be embedded into electronic health records to uh, educate, and uh, also in the lab order section. So the calculator program will uh, calculate um the risk score determination for a patient. So for example, for patient with who has a glaucoma risk, the calculator will be based on factors such as the age and the diabetes presence or absence. And based on these factors, the calculator can calculate the risk of having glaucoma uh, at the 5 years, the next 5 years. Um um, and the third feature is the flowcharts and graphs. Um Here we can use the flowcharts and graphs, like as you can see here, to look at lab or vital sign trends over time, so you can track the patient status uh, over a period of time. Um, so, for example, if the patient have a diabetes, it will be a greater assist to follow his readings, his diabetes readings daily, and compare it and use this reading to adjust or to improve his care or his medical care. The order sets, they are groups of pre-established inpatient orders that are related to symptoms or a specific diagnosis. So uh, there will be clinical uh, and evidence-based practice guidelines uh, to follow and to design a plan, the care plan for a specific order, sorry, a specific scenario or diagnosis, to standardize the medical care. For example, uh, there is an order set for pneumonia that might include the antibiotic uh, of the choice, the oxygen, repeat chest X-ray, and HC. So these guidelines can save time and save life. And also the order set can reflect best practice, because these practice are depends on clinical practice guidelines, which offer better and less expensive care. Then we have the reminders. They are computerized reminders that are part of the electronic health records, or CDSS, and they assist in tracking the yearly preventive health screening measures, such as a mammogram. So if the patient in a specific range, it can remind the patient or the clinician to have or to take a mammogram to prevent the risk of having breast cancer. The lab and imaging decision support. Um, Here we are, this system will help with what test to choose, the test or the appropriate test, and the cost of the test. So the physicians here, they particularly those in training, sometimes they order imaging studies that are um either incorrect or unnecessary. For that reason, several institutions, they integrate and implement the lab and imaging decision support to try to improve the ordering radiology and lab test. Differential diagnosis or diagnostic possibility. These are software that helps the clinician to analyze symptoms and signs to arrive at a diagnosis. So the clinician will input the patient symptoms, and based on these symptoms, the system will generate differential diagnosis uh, and questions to uh, arrive to the possible diagnosis. Last, we have the public health alert, where here the system, it's alert the public or the health organizations with the infectious disease for a new outbreak like the MERS virus, and like what we are experiencing now, the COVID-19. This virus was alerted and reported by public health alerts of different hospitals at the Kingdom of Saudi Arabia, and notify the Ministry of Health about having this disease in different regions and the number of the patients of that disease. So in this slide, we have different examples for the tools in the CDSS system. So this is a differential diagnosis system where the clinician can enter number of symptoms and the patient information to reach the most relevant diagnosis. And here we have the alert. So here there is a drug to drug interaction. So this is a warning and alert the physician that this because this patient is currently on a specific medication that can have an interaction with the prescribed drug. So the physician here need to change the drug to another appropriate drug. Here we have the calculator that is used to calculate the risk of the patient to have glaucoma. Um, so based on specific factors like the patient age, does he have diabetes or not? And here we have um, other factors, and we can calculate the risk. And here, based on the factors, we have the risk of developing glaucoma within 5 years. So this is the percentage of the risk with treatment and without treatment. And here we have knowledge support. We can use info button to have more information about the calculator, and also about the abbreviation uh, or the codes means. And also here we have information about specific clinical case. We can have more uh, information and clinical guidelines from the knowledge support system. Then we will talk about the health information exchange. So if the electronic records health records don't share data, we didn't change anything, but just we moved from a paper to electronic uh, silos, and this is not the goal. The main goal of having electronic health records is to be able to share data and use and analyze this data to improve the patient healthcare. And this is can be done by using the health information exchange, which is electronic movement of health related information among organizations according to nationally recognized standards. So here we can uh, move the electronic health related information between different organizations based on some national standard that are recognized by the world or nationally. And this is a critical element and integral to the future success of the healthcare reform at the local, regional, and national level. Uh, then we have the health information organization, which are organizations that oversee and govern the exchange of health related information among organizations according to nationally recognized standards. So these organizations will control and govern uh, the movement of the health related information between different organizations according to a national standard. So the health care data, which are commonly shared and exchanged, are the clinical results. So any lab, pathology, medication, allergies, immunizations, and microbiology data or result can be shared. Also, the images, which are actual images and radiology report, like these radiology tests and x-rays, documents like the office notes, the discharge notes, and also the emergency room notes can be shared. And also financial information, the claims data, and the eligibility checks when we check if the patient is eligible for specific treatment, and the claim data that will claim money from the insurance organizations, and also the medication data, such as the electronic prescriptions, the formulary status, and prescription history of the patient. All of these are important to be shared uh, between different organizations and entities. The exchange of health-related data is important to all healthcare organizations for several reasons. The continuity of medical care issues. So, by exchanging the information, um, we can be sure about the continuity of medical care of the patient wherever he goes, and biosurveillance, which they are systems put in place to monitor and interpret any data of biological, chemical, and agriculture threats. So it monitor the data and the cases of the patient that are affected by biological or chemical or agriculture threats. And we have also uh, it improved the natural disaster response because it make the sharing the data faster and facilitate the response in emergency situations. The quality of reporting will be better because the report will be delivered fast and will be available. Also, it is essential to improve research and data analytics to take the best medical decisions and to reach the best uh, information uh, based on research. With health information technology system, they need to embrace interoperability. Uh, the interoperability is the ability of two or more computer systems to exchange data information and to use the data and information that has been exchanged. So we don't just share the data between the different system. We need also to use the data and information for to improve the care of the patient. So this implies that the data is computable, structured, and that there are standards exist that permit the interoperability between the systems. So standards need to answer the following questions. How should the message containing the data be formatted so that it is computable and structured and organized? And how should well-defined values be coded so that they are universally understood wherever the patient goes? And how does the message containing the data will move from A system to a B system? So, uh, health information technology is not all different from other industries. It requires standards in order for parts to fit and computers to talk to one another. So, the ability to exchange and integrate data among healthcare applications is critical to the success of any overall healthcare information system, whether an organizational, regional, or national level of integration. Um, so data standards make information understandable to all users. It facilitates the transmission and sharing of data between different systems. So to exchange the electronic health records with health information organizations, there is a need to have a standard language that is understood by all the users. Um, Interoperability relies on syntax and semantics standard. The syntax is a concept that is related to the structure of communication, uh, how the communication is structured. For example, we have the CDA, Clinical Document Architecture, and HL7, Health Level 7. So, uh, to make it clear, uh, imagine the traffic light structure. Uh, uh, the traffic light structure is a syntax. So, for example, the green light will be in the bottom, the red will be at the top, and the middle will be the yellow light, and this is the structure of the traffic light, which means the syntax. And the semantics is a concept that denotes meaning of the communication. So it gives a meaning for the communication itself. Uh, if we return to our example, the traffic light, uh, the structure was just arranging the light of the traffic and choose the traffic light, but the semantics will give meaning to the lights. So, for example, the green means go, and the red means stop, and this is universally understood in around the world, that this is how the traffic light is structured, and these are the meanings of the colors of the traffic light. So data standards can come in many flavors uh, and have different types. One, the content standards or the syntax standards. They are the rules that dictate the format and the structure, the organization of information as it is packaged to transport and shared with different systems, such as the CDAs, clinical documents architecture, which are used in electronic health records, personal health records, discharge summaries, and also the progress notes. So as you can see here, this is an example for the data elements and how the sections will be organized in the electronic health records, and the description for each section. The second type of data standards, the terminology standards or the semantic standards, which are focused on the terminologies associated with electronic health records and the language used to code the entries in these records. For example, we have the LOINC, logical observations, identifiers, um, names, and codes. So this is a standard for the electronic exchange of lab results transmitted to hospitals, clinics, and also the payers by providing universal way of identifying laboratory observations. So, for example, we have this is the LOINC code uh, 806-0. This code represent the manual count of white blood cells in cerebral spinal fluid specimen. آه، اللي هي آه، عدد كريات الدم البيضاء في عينة من سائل النخاع الشوكي. And the third data standard, the transport standard. These are the standards that focus on the communication between multiple systems. So it answers the question how a message move from system A to system B. Example, the DICOM standard, digital imaging and communication medicine. And this is a standard for images and electronic health records to share digital radiological image test, medical images. So it enables the transfer of medical images in across systems and facilitates the development and expansion of the picture archiving and communication system. And these systems are used in the radiology system for archiving and communicating the medical images. So this is a standard that is used to transfer the digital medical imaging between different systems. So, for example, if you want to take uh, or yes, if you want to take a digital image uh, that you have done in the King Medical Abdulaziz City and consult another medical provider, you need to take the image as a DICOM or saved in a DICOM standard so it can be shared with the second medical provider. Medical coding. The coding are a representation of words in ways that permit processing by computer. So here we transfer the data into structured data. The medical coding, this is the process of assigning alphanumeric characters to standardize the description of the reasons for encounters between the patients and healthcare providers and the descriptions of all services and procedures performed, including the supplies. Um, so these medical coding used to represent any encounter between the patient and healthcare provider, and it will be understood universally. So, for example, terms such as uh, diabetes, if we want the medical coding for diabetes, um, um, the diabetes or the medical coding for diabetes in the ICD-10 uh, will be associated with the uh, code E10. E10. So any diabetic condition will be associated with this medical code. So the medical coding provide rich identifiable data for disease registries and research and epidemiological studies, and also data for quality improvement and performance improvement. And at the end, it improve for the uh, for the improvement of the medical and healthcare of the patient or the person. So um, the classification here, this is a grouping of terms with similar meaning. So the coded data will comes from the following coding and classification systems used today in the United States, uh, such as the International Classification of Disease, ICD. So the World Health Organization, WHO, publish publishes the ICD classification system to collect data worldwide on the causes of morbidity and mortality. So the ICD uh, need to be updated annually. Because of that, you can have different ISD classification system with different numbers. So we are at, this is an example for the ISD, the 10th version of the International Classification of Disease. Uh, we need annually or yearly to update the classification system because of the limitations on the expansion of specific categories of disease, um, and also the the revision of the system will be approximately every 10 years. So we have there are two types of the ISD. The ICD is 10 cm, the clinical modification. This is the International Classification of Disease, 10th revision clinical modification. This is the code set for classifying and reporting diseases in healthcare settings. And the ICD 10 PCS procedure coding system. This is the International Classification of Disease 10th revision procedure coding system, which is used in hospital inpatient settings for inpatient procedure coding. So these are diagnosis classification system. The We can compare the ISD-10 CM with the ISD-10 PCs by the number of the digits. So in the ISD-10, in the ICD-10 CM, we have the three from 3 to 7 digits. Uh, okay, and at the ICD-10, ICD-10 PCS, we have 7 digits always. So we have always 7 digits, and the CM between 3 to 7. For example, the ICD-10 we have this code R50.9, and it represents fever, unspecified fever. Uh, and example for the ICD-10 PCS is this code. We have 0, D capital, Q capital, 1 0 double capital Z, which means repair upper esophagus or esophagus, repair upper esophagus open approach, which means اللي هو إصلاح المريء العلوي أو عملية إصلاح المريء العلوي للمريض. So we reach the last lecture. Um, if you have any questions, I will answer the question on the live session on Thursday between 12 from 12 to 2 p.m. I hope to see you there, and you will be and make sure that you are available uh, to discuss the next assessment tools quiz, uh, inshallah. And thank you for listening.